So, for type 1 diabetics, this lifelong difficulty working with their blood sugar usually ends up leading to complications, quite frankly, about 90% of the people. And we already talked about the effects on the vascular system. So, when you consider that there's nothing they can do about this and it's been going on for a long time, they really do deal with the situation of chronic hyperglycemia. And so good blood glucose control is really helpful in preventing or delaying microvascular disease. And so one of the really important things is for these patients also is to monitor their A1C. But it's interesting that it is a little bit different for type 1 diabetics than it is for everyone else. So as usual, the lower the result, the better the control. But the target for a type 1 diabetic is 7%. Now, that's interesting when we consider that the threshold for diabetes is 6.5%. So their target is still on the high side, but considering that this is a lifelong battle, that's about where we mark it. Now, macrovascular disease is an issue. And when you consider that we leave the threshold a little bit higher, and this is something that they deal with over their lifetime, macrovascular disease does have an earlier and more extensive onset. So those larger arteries are more likely to be affected. So something else that we have to think about is controlling the cholesterol and the blood pressure. Controlling the blood glucose alone is just not enough. So yeah, we have to control the sugar, but we also need to think about their cholesterol. Look at the blood pressure, look at that as a gauge. And so we do have an important role to play in educating patients. They may hear this from their doctor, but many times it's kind of like you need to hear things from multiple places, sometimes to grasp the seriousness of it. So we do have a role to play in continuing to educate them. So right now, the current approach for managing type 1 diabetes involves multiple insulin injections every day. On top of that, type 1 diabetics also need to maintain a proper diet. They need to be exercising and looking at the blood glucose levels to make adjustments. There really is no cure currently. One of the things that they struggle with is low blood sugar, and that can result in insulin shock, especially from the multiple insulin injections that they're getting throughout the day, because they are managing, looking at their levels, making adjustments, making calculations. And so they can end up with this severe hypoglycemia. True insulin shock, true hypoglycemia is a true medical emergency and one we need to be prepared for. So when you have patients who indicate that they deal with type 1 diabetes, we want to determine, are they brittle diabetics? Now, with brittle diabetes, that means that they've got glucose levels that keep swinging from high to low. And it's not about them failing to control it, not about them failing to take their medications. It's just despite their best plans and being well managed by a physician, they're just not able to keep things under control. So we want to be on the lookout for patients like that and be in good communication with them. So what are some of the treatments? So currently there are oral hypoglycemic medications, the same type that are used in type 2 diabetes, and then they combine that along with the typical insulin injections. There are also some other things that have been out on the market, and these include certain experimental therapies such as transplanting pancreatic beta cells into the liver. And what's really interesting about that is that they use the liver because you can reprogram liver cells to become beta cells. So they almost act like stem cells. But something to be aware of, especially if there's some sort of transplant, they may also do some things where they work with mouse liver cells and then stimulate them to take on pancreatic features. But that's really an organ transplant. And so if they work with transplantation of islets, then the patient has to take drugs every day to make sure that they keep their body from rejecting these little islands of cells. And then there's the insulin pump. And so they've got the fast-acting insulin, the Novolog, and this one is going to work automatically. It's injected hourly with lower doses, and the idea is that it's monitoring and giving better control. And then there's the external blood glucose centers and transmitters. They alert the pump, and then the pump alerts the patient that they need to administer a dose. So in type 2, the non-insulin dependent diabetes, this one is a little bit different. This one is characterized by insulin resistance. So this is the majority of diabetic patients. This one comes on gradually. It's usually something that we associate with older adults, and it's also usually found in association with obesity. So our thought is that it is something that should be preventable. What we usually see it with is, this weight gain over time that usually happens with older people, although lately it's been increasing with children. And that could be for social factors, cultural things like our diet in the United States or in the Western diet. It's obesogenic, and it's spreading throughout parts of the world where they never had an issue with obesity. Taking on American foods or Western foods has started to cause issues for people. And so again, here's an area where we have a role in education. So we do talk about nutrition, and this also ties in with diabetes, not just the caries prevention. So how does it work? Well, obesity, the thought is, how does it create insulin resistance? Well, the thought is that the obesity decreases the number of receptors for the insulin binding in fat and muscle. So yes, there's the glucose in the bloodstream, and yes, the insulin is being released, but it's like the body cells themselves are not taking them up. And then we have adipokines, the hormones from fatty tissues. The thought that those may be contributing to insulin resistance. So excess fat becomes its own hormone producing organ, so to speak, and then that creates an insulin resistance. So when a person has type 2 diabetes that is poorly controlled, or what we might call marginally, just barely controlled, they deal with the same complications that we saw in insulin-dependent diabetes or type 1. And that's also really concerning because, as we said, we're starting to see type 2 diabetes in younger people and children. And so it's kind of like the issue that type 1 diabetics have, where they're dealing with this poorly controlled blood sugar over a long period of time, leading to, without doubt, some complications later in life. Well, if we've got children dealing with type 2 diabetes over a longer period of time, not starting in their 40s, they also will deal with some of those same life-threatening and debilitating complications. And so when it comes down to treatment, some of the standards, diet and weight reduction alone could be used. Then there's oral hypoglycemic agents. So the idea is that they'll improve insulin production from the pancreas and then the binding of insulin to the target tissues. And then some even use an insulin pump for those who take multiple insulin injections. You may see some in the arm now where patients don't have to do injections throughout the day. In addition to insulin, there's now just very many oral injectable medications available. There are also hypoglycemics, and they look at a variety of ways to go about controlling the blood sugar. Some decrease the glucose production by the liver. One of the great examples of this is metformin or glucophage. This is something that you'll see many patients on in your practices. And this is typically a first-line treatment. So when patients, the doctor may first put them on a diet and exercise regimen, and if that's not sufficient, then metformin is usually the next, that first-line method for them when we go into medications. And then they may also work by stimulating insulin release from the beta cells, maybe improving the response to insulin from the body tissues, mimicking the action of the glucagon peptide. So it works with other hormones and bodily functions to control glucose levels in the blood. That's what glucagon does. And then some of the newest drugs work to excrete glucose through the urinary tract. So gestational diabetes is completely a separate classification. This can occur in pregnancy, but it doesn't happen all the time. And so screening is recommended. It's a part of routine prenatal care because it's important, but it does disappear after pregnancy. What's interesting, though, is there are usually no noticeable symptoms during pregnancy. There's just this increased birth weight of a child, fetal macrosomia, but the mother and the child both now have a higher risk of developing type 2 diabetes later on in life, interestingly enough. So, some clinical features of non-insulin dependent diabetes. So, of course, the vascular system is adversely affected. We talked about difficulty with resisting infection, diabetic retinopathy, the blindness, nervous system effects. But something else interesting is this acanthosis nigricans. This is a skin disorder that we see with type 2 diabetics. So, with obesity, with the children and adults, it seems to increase the risk of developing this skin condition. And we'll take a look at that. And in it, what you'll see is hyperpigmented velvety textured plaques. So they're going to be distributed symmetrically in the folds and creases of the body. So you can see we have a patient here who is obese, and you can see it on the folds on the knuckles and also on the back of the neck. And so the hygienist, you as the clinician, you will be alert to notice this condition, to see this, what's going on. And maybe if you see it among friends or family, it could be ones who are not yet aware of their condition. And it's something that you could perhaps point out, make parents aware of it for your patients, or just help your loved ones. So let's talk about some of the oral complications, because this is where this really comes in for us. These conditions are most visible when blood sugar is poorly controlled. So oral candidiasis is one of them. Mucormycosis, which we've talked about in earlier chapters about, it's a fungal infection that can show up. Something else that you don't see too often is this bilateral parotid gland enlargement. It is asymptomatic though, and may even be related to xerostomia. So xerostomia has to do with this dehydration of the tissues, this dry mouth, and then with that dry mouth condition, it can increase the chance of developing candidiasis, caries, and even with dealing with burning mouth syndrome that can also be related to it. Something to be aware of with burning mouth is that it could be found, you could be the one to realize that someone has an undiagnosed case of type 2 diabetes. Also, with diabetics, they may have an accentuated or egregious response to plaque in the mouth, hyperplastic and erythematous gingiva, so overgrowth, very red, unable to control that infection, and increased likelihood of gingival abscesses. So with perio, this really is a significant complication of diabetes because we have this inflammation in the body that then makes it harder for the patient to control diabetes. It also works on the flip side. So uncontrolled diabetes, in turn, if their blood sugar is uncontrolled, makes it very difficult for you to control the periodontal condition. And so they're complicating each other. So having perio is a significant prognostic or predictive clinical marker for diabetes, particularly when you just can't seem to get it under control. So what's your role? Education, education, education. And so ask questions. Ask the patient about their A1C. When did they have their last meal? If you know that they're diabetic, did they eat? Have you checked your blood sugar today? You may even ask what it was now that you're aware of what it should be. Make sure your type 1 diabetics have a backup supply of syringes if they're on a pump, and then be alert if they're on some sort of pump to signs of pump failure. So we know that things are pretty critical for them. Things can change quickly. So if you've got a type 1 diabetic, look out for signs of hyperglycemia, ketoacidosis, nausea, abdominal cramps, disorientation, fatigue, these sorts of things. Be sure to have an office, a glucometer, and test strips if someone hasn't checked or you're concerned. And then a fast-acting carb. A lot of times we'll have frosting or something in the office to help prevent insulin shock. And next we'll go on with Addison disease.